Okay. Okay, next case.
Yes, I'll
So
take over.
thanks, Laura.
Yes, so this patient presented to me. He's 25-year-old male, and he presented with first and second MTP pain. At that time, it wasn't a year, but with the case, by the time it reached Dr. Cruz, it was a year. So the symptoms that he came in with were worse pain with weight bearing, stretching, or specifically squeezing the forefoot. The pain also felt like there was a lump on the plantar aspect in the area, the same area of the pain. The pain was quite high. The pain was about a 7 out of 10. He's just been using some medication orally for pain, and there hasn't been much change. At the time, with asking about in his history if there was any injuries, any past medical conditions, or family histories of any conditions, there weren't any. And the only thing that he did present with prior to the injury was he did have the history of left hip pain. And the pain was also on the left foot as well. So this patient, I asked about the social history, runs a couple times a week for about 20 minutes, plays basketball, is quite active, and he walked around a lot. So this patient was a student and also worked in a lab. And now, unfortunately, he can't really walk without pain. He can't even commute without pain. So once they presented to me, they did say that they already had an x-ray and ultrasound, and everything was seen as normal. And what else would we like to know? Okay. What else would we like to know about this patient?
I can start. Has he had similar pain in the past, or this is a new first time?
That's a great question. And this is the first time. So the only pain that he presented with prior to the visit was there was a little bit of hip pain. But other than that, this is totally out of the blue. He was very active before, and the only thing that I asked him was certain movements, and the only thing he did recall was pushing in the lab. He pushes the door with his toes a lot to prop them open, and it's quite a heavy door. He kind of felt around that time this started.
And he wears terrible dress shoes. He's got to have the look, right? He's got the dress shoes on.
Yes, the dress shoes. What I might have asked was, at what time did that x-ray happen, or when were the diagnostic tests done? And they were actually done around the time of the injury, right the same week. Is there anything else you may want to know about this patient?
Was the lump on the foot like there in the same time that he started getting the pain, or was that before?
Good question. On the initial appointment, no. When there was subsequent appointments, the lump did he just noticed it kind of later down the road. So that kind of adds to a little bit of the story there. So initially when he presented, no, but on a subsequent appointment, it was noted.
Mm.
He has no other history of anything else. So like no other metabolic problems, no autoimmune problems. He has no psoriasis, no colitis. And there's nothing particular in his family history either.
So we'll move on to the next slide. So upon physical exam, so as Dr. Cruz mentioned, yes, he does like to wear his dress shoes. Pes planus foot type, hip strength was a bit reduced through abduction. The ankle range of motion was normal. There was pain on direct pressure of the first and second metatarsal head, and painful toe extension and flexion. So movement really aggravated the area. And I did test for a neuroma, and that direct pressure so neuroma is more interdigital. The pain was actually direct pressure of the med head. But there was no pain really interdigitally. And also there's just the foot could have used a little bit of strength at that time. So I advised some foot strength. And so what do we think we might be dealing? What are some differentials that come to mind here?
Was there any dropping of the metatarsal heads? Like, they were positioned normally?
That's a good question. They were normal. Nothing was dropped at that time.
Plantar plate type, nothing.
Nothing dropped.
Okay.
There was a little bit in the nose. There was a slight bit of swelling at the time, but nothing actually too alarming. Just a little bit of swelling on the dorsum of the foot and right a little bit underneath the area of pain, but nothing alarmingly, nothing too significant at the time.
So with a remote ultrasound and X-ray, I'm less, although it was remote, I'm less concerned about something like Friedberg's disease or syndrome, where there's that weird flattening and osteonecrosis of the second met head. And yet, that can evolve. So if it's normal and it hasn't started collapsing in, it may have been interpreted as normal on an X-ray that was done, say, a year ago. So that may be something I would want to look at again if I can't think of anything else. I don't think he's a high enough volume exerciser. He walks in terrible shoes, but I don't, and someone who's got reasonable bone health, so, a fairly robust, vigorous looking, well-nourished man, I wouldn't be thinking of stress fractures, but he may have bone weakness and sensitivity to stress reactions for reasons that weren't completely clear based on the history to date. So it could still be a stress reaction. I think I tried to examine for this, Laura, but the other thing, I see a lot of people with hypermobility, so I'd be wondering about subluxing MTPs. So you just dropping that toe out. So is there a plate injury, as you've, suggested, Kate? Even though he's only painful more on the bony prominences, I would still, want to be sure there wasn't anything in the interdigital space.
Good. Yes, those are all great differentials. And that kind of what sparked my concern was the fact that there was an X-ray done quite near the time of the injury. I know sometimes there can be a delay in when they show up, and the fact that it was swollen. I do know that usually the second metatarsal head is prone to injuries in a flat foot because that second met head tends to take a lot of the load as well. So I was just concerned, and that's out of my scope. So at this point, I was starting to raise a little bit of red flags, but he was sent to me. So the next slide, we'll see where we are there. Okay, yes. So we have metatarsalgia, plantar plate, capsulitis is another one that I see. So sometimes that second metatarsal head, there can be a little bit of injury to the joint space and the capsule, as well as that concern about the bone injuries. Okay, so the treatment plan that I went to was, at the time he was sent to me, he already saw someone who interpreted the X-ray and said maybe you should try seeing a foot specialist with a bit more support. He had a current pair of orthotics that they were pretty soft, so I decided to try a MetPad for him. We gave him some foot exercises, and as well, I also advise working with some physiotherapy to help strengthen his hips. And potentially I was also kind of considering maybe some of the flexor tendons might be a little bit inflamed, so potential shockwave therapy. And the steroid injection was another option as well. So what else should we consider here when treating this patient?
I'm not quite sure what a MetPad is, but with some big toe pain, especially get some pain extension, you can, I think there's like a Morton extension or some type of more rigid footwear that reduces the range of motion of the big toe, and that can relieve some pain, especially with ambulation.
Yeah, great. So one of the things that down the road, once we dealt with this, was a bit more supportive footwear. So the Hokas are great. They're a lower foot drop. They have a lower drop. We'd like to recommend that for people. And they have a 4-foot rocker. And sometimes they actually have, I think the Cliftons now have a bit more stiffer forefoot. And some of them even have a carbon plate in them. So those are sometimes excellent shoes to provide as an option for patients with these type of issues, like you mentioned. So it kind of provides that rigid Morton extension without having to go through the orthotic route. That's actually designing the whole shoe. So that's definitely an excellent option. And we did recommend more supportive footwear. No more Aldo shoes. Okay, so there was some follow-up. So during the time where I was helping out this patient with the met pad and potential orthotics, they were also seeing a sport medicine doctor as well. The sport medicine doctor did do a cortisone injection into the area. And unfortunately, the injection did not give too much pain relief for that patient. And at this time, once I heard this, I was kind of starting to get really concerned about the patient. I said, okay, I still had that in the back of my mind, something to do with the bone or the joint health. So I decided at this point, I wanted to refer to Dr. Cruz. I've been able to refer to her for a lot because I can't order x-rays. So I felt the need to write a referral letter to her. The patient, the only problem is the patient is traveling. So he's leaving for a long time for an extended period of time to China. So that's where the follow-up was with that patient. Okay, so then seen by the second. So this is when I have referred to Dr. Cruz. And then at that time, the joint was quite swollen. And we also requested possibly more x-rays. And there was also at that time when we had another x-ray and ultrasound, there was some swelling in the joint. And then also they have been seen by a rheumatologist by this point. They've been given oral prednisone, and the only thing that the patient can wear is a walking boot because they're in so much pain. And the MRI showed joint effusion, no erosions, bone marrow, edema, plantar plate tear, and a subluxed metatarsal MTP.
So all the things we talked about.
Yes,
Except the one we didn't talk about.
correct. So what
In addition to.
there was also a that little there was a bursa, an interdigital bursa as well. I believe that was on a different area though, not in the area of pain. So that maybe what he was feeling was in another area. So what else might we want to be considering thinking about with this patient? Any other things that might be coming to mind here for this patient?
John, what do you think's going on with him? He doesn't have Friedberg's, he doesn't have a stress fracture, he's got an effusion, plantar plate tear. So, there's a mechanical problem with that toe, maybe that's the doorway thing, but that doesn't give you an effusion. And it doesn't give you dactylitis.
And they're being seen by rheumatology.
Yeah, so he ended up seeing Rheum sort of by the by for the hip pain. And so Rheum was working him up for some inflammatory problem. And because his walking was so impaired, it was just like, oh yeah, no, my foot's been really sore. So Rheum started getting involved with that as well. And so, between the China trip and then seeing me and then doing other stuff and then seeing rheumatology, things were kind of coalescing at the same time.
Yeah, I would be. I'm thinking I would be tempted to chalk this up to mechanical factors, even the swelling, if there was continued irritation of the joint from biomechanical factors from the tear and the subluxation of the joint, especially in the context of no signs of infection or inflammation of the joint, like if it wasn't red and other signs of infection.
Yeah,
Or-
the day that I saw him when he had the dactylitis, I mean, there was some diffuse edema. It's not recorded there but dactylitis is sort of again a bit of a harbinger of some sort of inflammatory process, and it didn't look
Yeah.
like an infected toe.
I think that's associated with
Yes.
with psoriasis or
It can be, it's associated with usually rheumatoid arthritis, but it can be associated with other inflammatory arthritides. So I think, and it just worked out. He was still seeing Rheum, and Rheum was getting involved with respect to the foot. There was a delay even in getting the MRI because he had to get approval from his insurance company. So we put this together in probably the incorrect chronology. And the MRI came back fairly late. So the boot cast and the prednisone was really to try and treat the pain and get him ambulating. And the MRI came sometime later after approval was given. So the insurance company had to pay for it. He's a non-resident, so.
I'm curious about just, and I'm not sure of the chronology, but if the cortisone shot was not effective, and I don't know what necessarily the indication was from that giving oral prednisone, what sort of the indication was for that, if it was potentially not an inflammatory condition because the cortisone was not effective.
So we don't know the dose of oral prednisone. Usually they'll start with 10, but they can go all the way up to 50 for a burst. And if it's a systemic and constitutional problem, then whatever the dose of cortisone was, we don't know where the cortisone was injected. I didn't do that injection.
Yeah.
So I don't disagree with you, but I think that's that's sort of a rescue maneuver that rheum will often do.
Yeah.
To try and dampen down stuff.
Yeah.
So, upon follow-up with a rheumatologist, he was diagnosed with an autoimmune disorder called peripheral undifferentiated spondyloarthritis. So he just had ongoing treatment with oral prednisone, I can't pronounce these words, Doc.
Sulfasalazine. Sorry, I may have spelled it wrong.
No, I'm just not familiar with that.
Sulfasalazine's got an extra Z. I apologize.
No, that's okay.
And luflanomide.
And also the knee crutch. So, to be honest, I don't know long-term how that patient is doing after we've gone through all this, because they have been bopping around, and I did recall them saying they may actually move back to China for a bit. However, this case really resonated with me because it was one of the ones that really scratched my head. I didn't know. And lo and behold, there was multiple different things that we thought of were also going on. So that can also maybe even hide something. It kind of taught me that, there can be two serious things happening at the same time that can coexist. So we don't want to just maybe think, oh, one thing is only going on and we can forget about something else. No, two things. You can have a plantar plate tear and also have a rheumatological condition going on at the same time. So that was a really interesting case for me.
Do you think one contributed to the other? So like, I get the whole process of like holding the door open with the toe, but potentially with the joint effusion, like, would that have, like, in your experience, would that put so much pressure on that plantar plate that would make him vulnerable to that? Or like, is it a domino effect, or is it just unlucky that this happened and it clouded our judgment?
Yeah, I do feel as though that type of movement can definitely injure a plantar plate. And a lot of times that can be what can cause some capsulitis to happen, where there's a hyperextension injury. And maybe, I don't know, I'm not a rheumatologist, so I don't know if something like that can kind of all of a sudden ignite a rheumatological condition. But it definitely allowed us to find out what was going on, though. What's doing all the examinations and x-rays.
Yeah, I was thinking like almost in the reverse. So like the autoimmune disorder made him vulnerable to the plantar plate injury. I'm just wondering, like.
Yeah, to be honest, I don't know. I'm not sure on that one. I don't know if Dr. Cruz has any experience in that regard.
There's no doubt that tissues do become more fragile and friable whenever there's a constant inflammatory process going on. I think it's hard to know, and I don't know, Kate, how long that has to be there before that tissue becomes more sensitive. And I think had there been erosions there on the X-ray, I would have said yes, there had been enough inflammation there long enough. But I think when he came back and he had that clear dactylitis, that clearly the inflammatory process had sort of taken off a bit more. But yeah, that's a good question. And certainly we see that like in shoulders, people with rheumatoid arthritis in their shoulder, everything just breaks down after a while. So everything's just being destroyed by the inflammation. So had there been erosions on the updated imaging, I would have said, yeah, no, that tissue was just really being rotted away by the inflammation. But in the timing, I'm not sure. I think it's a nuance a rheumatologic nuance that I can't help with.
Laura, can I ask you just a quick question as well? If we see runners a lot, and I know like Nike's making that carbon plate that you're talking about, is that something that you would recommend if you're suspecting a plantar plate issue? Like if we take away the, like this specific case, like, do you find that's really helpful with the plantar plate or like?
Yeah, great question. Yes. That's why I was suggesting before the Hokas are great too, because some of the Nike ones have a higher drop. So
Right.
they're, whereas the
Yeah.
Hoka is nice because it's a bit more at a 4 mil drop, and it does have more of that rocker built in. And it's a bit wider. So that's kind of why that one, but for sure it will help because you don't have that hyperextension happening. So I, with any hyperextension injury, even some sort of like, I found success with the Met bar pad over a Met pad, but it can just help stabilize that joint a bit so it's not undergoing as much extension. But yeah, it definitely will help.
And then, sorry, did you say the Hokas do have the carbon plate, or is it just the forefront rocker that you're talking about?
The Hokas have both, so you can
Okay.
get one just a cushion without the carbon plate, but they now do have one with a carbon plate in it.
Okay,
Which-
thank you.
So you get the rocker, you get the low drop, and the carbon.
Perfect. Thank
Do
you.
they all have the same rocker, Laura, or is some a little bit more than others?
There are definitely some more than others.
Yeah,
You just kind of have to look at it, put it down, and see the
Yeah.
angle when it goes up. But for the most plate, every line now does have, because they're all trying to compete, so they all have like a carbon plate. Every shoe brand has a carbon plate now.